Good evening, everyone, and a very warm welcome to today's academic session of Spice Road Kerala chapter. For today's session, we have an obstetrics clinical case discussion. I would like to welcome Dr. Aysha, DNB Family Medicine Resident from Iqraa International Hospital, Calicut, who will be presenting the case today. So we are privileged to have Dr. Febin Koya, consultant gynecologist and laparoscopic surgeon at Iqraa International Hospital, Calicut, as our session moderator. Welcome to the session, ma'am. We are delighted to have you with us.
Sure. Thank you, sir. Thank you.
A warm welcome.
An opportunity also to be a part of this case presentation.
Okay. Warm welcome to all the students and participants who have joined us today. Without further delay, let us begin the session. Dr. Febin, over to you.
Okay, so I think anemia in pregnancy is actually one of the very common problems that we encounter. And especially in a developing country like India, we do have a lot of caseload for this. And most of the places, unlike Kerala, are not having a structured health setup that every pregnant woman can utilize. Because in our state, whenever we do have any pregnant patient, all the Asha workers and the Anganwadi workers, they do go behind them, make them register, and ensure that they are having adequate iron supplementation as well as the 2 doses of TT. Everything is being taken care of. But mostly in the other states, we do encounter a lot of problems of anemia in pregnancy. So I think Aysha can start presenting the case. And so we'll go with the case presentation. And if I have some disparities or change in opinions, I shall intervene in between. And after that, we'll go to the discussion of the topic proper. Is that fine?
Yes, ma'am. Can
Okay.
I start?
Yes, now you start presenting.
Good evening, all. Presenting the case of Mrs. XYZ, 26-year-old lady who have completed her B.Ed education and currently working as a high school teacher. She's Muslim by religion. She's from Calicut and belongs to upper middle class family. Date of examination, 7th January 2026. And she's a primey. Her last menstrual period is 12th of May 2025. Expected date of delivery on 19th February 2026. Period of gestation 34 weeks and 2 days. Here is a booked case of primary gravida with 34 weeks plus 2 days of gestation who came for regular antenatal checkup and detected to have low HB on routine blood investigations. Coming to the history of present pregnancy, first trimester, she was detected to be pregnant by urine pregnancy test done 1 week after missing period, had regular antenatal checkup since then. Spontaneous conception, folic acid taken, dating scan done at 7th week and date confirmed, first dose of TD vaccine taken, routine blood investigations done were normal. NT scan done at 12th week was said to be normal. Double marker test was negative. 75 gram glucose challenge test done normal. No history of excessive vomiting, bleeding per vagina, abdominal pain. No history of fever with rash. No history of urinary tract infection. No history of radiation exposure or other drug intake. Coming to the second trimester, folic acid tablets were continued.
Second, okay. So she had an uneventful first trimester of pregnancy, right?
Yes, ma'am.
Almost everything was normal. She was doing all her antenatal checkups. And what is your take on folic acid supplementation before pregnancy as well as during the first 3 months of pregnancy?
She actually started taking after detecting urine after the UPT become positive.
Okay. So is there any role for folic acid supplementation before pregnancy itself?
Yes, ma'am.
Okay. Why do we suggest that to patients?
Because actually it will prevent any neural tube defect.
Neural tube defect prevention is one of the major thing, right?
Yes, ma'am.
But do you think we have folate deficiency in our community?
Yes, ma'am.
Folate deficiency can actually coexist with iron deficiency, right? Folate as well as megaloblastic anemia, that is vitamin B12 deficiency can be there. So ideally, this folate supplementation before pregnancy itself is a saving factor, like 400 micrograms of, that is what we suggest, but all our preparations come as 5 milligram tablets. So what we give patients is the same 5 milligram tablet every day for at least 3 months prior to pregnancy. And you can actually give it for other patients, like those who are having recurrent miscarriages also. For such kind of patients, we do suggest this 5 milligram of folic acid tablets prior to pregnancy. Okay, so this folate deficiency correction can happen if they are having a planned pregnancy where they start 3 months of folic acid prior to their conception. Now we continue.
Moving to second trimester, folic acid tablets were continued. Iron and calcium tablets started. Second dose of TD vaccine taken. Quickening felt at 17th week of pregnancy. Anomaly scan done at 20 weeks and was said to be normal. She had history of fatigue, dizziness, increased sleepiness, and dyspnea on climbing stairs. No history of palpitations, no history of edema. CBC complete blood count done showed a hemoglobin level to be 10.6 gram per deciliter. Advised to continue iron tablet twice daily, but she refused in view of dyspeptic symptoms and continued as usual, that is once daily tablet. Dietary advices were given and were followed. FBS, PPBS done were normal. No history of headache, nausea, vomiting, blurring of vision, epigastric pain. No history of bleeding or leaking per vagina.
So you were talking about the second trimester, right?
Yes, ma'am.
And she had a HB of 10.6. So
Yes.
why do you say that it is anemia? What is the cutoff range for the hemoglobin levels during second trimester?
Actually, there are two cutoff values according to WHO and as per, according to ICMR. According to WHO, less than 11 gram per deciliter in any trimester is considered as anemia. And according to ICMR, there is grading of anemia. That is between more than 11 is the required normal range, and between 10 to 10.9 is considered as mild anemia. Between 7 to 10 is considered as moderate anemia. Less than 7, severe anemia, and less than 4 as very severe anemia. So this patient comes under moderate anemia.
Moderate or mild?
Mild anemia.
Yes, it comes under mild anemia. And what is the prevalence of anemia in pregnant women in India as a whole?
More than 50%.
And there are some studies, yes, there are some studies say 55%. But I think if you consider the north side, it will be more. If you consider the south side, like in Kerala, it will be a little bit less. But anyhow, it is around some 50 to 70%, which is a very high prevalence, right? So if we take this cutoff, again, this if we take the cutoff as 11 gram percentage, again, this will be a very high rate. So you were specifically telling that her HB value was low during the second trimester of pregnancy. So what are the changes that actually cause physiological anemia of pregnancy? What do you mean by physiological anemia of pregnancy?
Physiological anemia of pregnancy means there will be increase in plasma volume by about 50%. And but the red cell mass will increase only by 20 to 30%. And this is to decrease the viscosity of the blood and thereby increase the placental as well as fetal perfusion.
So there is a hemodilution basically, and that causes a physiological anemia of pregnancy. So usually there will be a drop in the hemoglobin levels during the second trimester of pregnancy, and that if it is more than 10, usually it is called to be physiological. So most probably in this patient, what must have happened is that she had a physiological anemia of pregnancy, right? Because her hemoglobin levels were 10.6. Okay, so what are other pathological causes that cause anemia during pregnancy?
Iron deficiency. That is deficient intake and absorption of iron, inadequate diet.
That is the most common cause, right?
Yes.
Iron deficiency anemia.
Then folate deficiency can cause anemia. Vitamin B12 deficiency. Then any hemoglobin.
So all of these would come under nutritional anemia.
Nutritional.
Yes. Then what are the other causes?
Then chronic blood loss, as in case of hookworm infection, chronic
That can
renal
happen.
then chronic malaria.
Yes. So infections like hookworm infestations, malaria. Then
Then
then what are the other causes? What do you say?
impaired absorption.
There can be impaired absorption. So that will come to causes like
malabsorption syndromes and all.
malabsorption syndromes and inflammatory bowel disorders. All those can happen then.
Then increased demand for iron.
Increased demand for iron is there during pregnancy. So how much of iron is, how much is the increased demand of iron during a pregnancy state?
Net requirement is about 900 milligram.
Almost 900 to 1000 milligram, but some say even 1200 milligram. And how much of iron is actually saved because of the anemia, because of the amenorrhea during pregnancy?
300 milligram.
Somewhere around 200, maximum of 300 milligram, or somewhere around 150 to 300 milligrams. So there is a net requirement of almost 800 to 900 milligrams of iron during pregnancy, right?
Yes, ma'am.
So that is the reason why there is an increased demand. So pregnancy itself is a condition which can predispose to anemia. Then what are the other causes? You are missing some important causes which has to be ruled out.
Hyperemesis and all. There will be deficient in intake and absorption of iron.
Leave all those. You're actually evaluating a patient for anemia, and you find that she doesn't have any iron deficiency anemia. So what other causes can be there? What other causes has to be evaluated?
Other causes such as sometimes it may be due to repeated pregnancies with inadequate spacing. That can also
all those can be there.
Hereditary causes such as thalassemia, sickle cell anemia.
There are so many patients when we evaluate, we don't find any other cause, but there may be a thalassemia that is existing, and she may not be knowing that because she may be a trait, okay, or she may be minor trait. It's not necessary that it has to be a thalassemia major, okay. This can happen, yes. And other causes are sickle cell anemia also, because in the belt of Wayanad, I know there are some areas where there are sickle cell anemia. So all those causes has to be ruled out. And other things are like chronic diseases, like a chronic liver disease or a chronic kidney disease. All these can predispose to anemia. So what actually, how does would this iron deficiency anemia happen all of a sudden, or does it happen gradually?
Actually, occur very gradually. It starts from the childhood itself. Also, the diet during the adolescent period, and stores in the adolescent period also affect the reproductive age group.
So the thing is, actually, the first stage is there will be depletion of the iron stores. Okay. And the second stage is there will be a state of iron deficiency, and then happens the anemic part. So mostly what happens is whenever there is an increased demand for iron during pregnancy, all the patients will be invariably depleted of their iron stores. So whenever they are depleted of their iron stores, this huge demand that comes will bring anemia in them. Okay. Then what is the daily requirement of this folic acid that I've already discussed, right? 400 micrograms should be there. So what are the dietary importance of food? I mean, what is the most important diet that has to be consumed by pregnant women so as to prevent all these kind of anemia?
Diet should be rich in green leafy vegetables, which are rich in iron.
So which are the green leafy vegetables that are rich in iron that you will suggest for your patient? Okay,
spinach, drumstick leaves. Then also
all the
then cereals such as ragi, jaggery.
Yes. So all these things like the spinach, moringa leaves, all these things are easily available in our community, but most of the patients don't prefer that. Okay. So this can be advised, or this idea can be reinforced into them that in order to have a good hemoglobin level, they need not go with any fancy food items. All they have to do is use these kind of green leafy vegetables, ragi, jaggery, all these things which are very rich in iron, and they can incorporate it into their diet like once or twice in a day. So whenever any patient comes to you for a pre-pregnancy this thing, pre-pregnancy counseling, you can actually ask them to start changes in their diet so that their iron values as well as the storage will increase.
Okay.
Mm. Then, what is the mechanism behind anemia of chronic disease?
Anemia of chronic disease, there'll be decreased erythropoietin synthesis,
One is decreased erythropoietin synthesis, especially in patients with chronic kidney
chronic
disease.
kidney disease.
Another one is
Malnutrition.
not malnutrition. There will be an increased levels of circulating hepcidin. So this hepcidin, what happens is it blocks the iron release from the enterocytes. Okay.
Okay. Okay.
And the reticuloendothelial system. So this is the reason. These are the two reasons. One is decreased erythropoietin, another is increased levels of hepcidin. Okay.
Okay.
And there can be very rarely there can be cause of aplastic anemia, but usually that doesn't. We don't see such patients. Mostly it is this iron deficiency anemia, folate deficiency, megaloblastic anemia. Then comes chronic diseases and hemoglobinopathies. Okay.
Okay.
Now you continue.
Moving to third trimester, continued to perceive fetal movements. Iron and calcium tablets were continued. Her symptoms of fatigue, dizziness, increased sleepiness, and dyspnea on climbing stairs had improved. Repeat complete blood count showed HB to raised as 11.3 gram per deciliter. FBS, PPBS repeated were normal. Growth scan was done and said to be normal. No history of headache, nausea, vomiting, blurring of vision, epigastric pain. No history of bleeding or leaking per vagina.
So all her third trimester was almost uneventful.
Yes.
Okay. So what are your clinical examination findings or the rest of the history? Are there any significant things? What about her dietary history?
I will the menstrual history അങ്ങനെ പറഞ്ഞാൽ മതിയോ മാം?
Menstrual history, all you have to rule out is that there was no heavy menstrual bleeding prior to her. Okay, then.
Marital history, married at the age of 22 years, non-consensuous marriage, no history of infertility treatment. Husband is an IT professional, studied till MTech.
Okay.
Past history,
nothing significant, right?
History of PCOS detected at the age of 18, took a short course of hormone therapy. Other details not available. Then family history of bronchial asthma in mother. Then coming to the personal history, first of all, dietary history. I have written about the brief about the first trimester as well as second trimester diet history. First trimester, her diet was rich in carbohydrate, but deficient in protein, iron, and calcium. Average diet at 8 a.m. She consumes about 2 dosha with sambar. 11 a.m. fruits such as apple or orange. Then 2 p.m. Patiri or dosha like that, and with banana, one banana. Then at 4 p.m. 1 glass black tea and upma. Then 9 p.m. 2 chapati with a fish curry. And she consumes egg about twice a week, meat once weekly, does not consume fish, leafy vegetables, dry fruits, milk, and iron-rich fruits.
So typically, all she had was more of carbohydrate, what we have mentioned, and only a little bit of proteins as well as this thing. So ideally, in pregnancy, what you should advise your patients is most of the time, definitely they should consume carbohydrates, but that has to be mostly what kind of carbohydrates? Complex carbohydrates. Complex carbohydrates are better for them, right? So that should include like most of these things which she was consuming didn't have any fibers or this vitamin B, like cereals with brown cereals were not present. So she can actually have oats, brown rice, all those kind of things, then sweet potatoes, all kind of complex carbohydrates can be incorporated while we focus on carbohydrates. And about proteins, even though she was a non-vegetarian, was she a non-vegetarian or a vegetarian?
Non-vegetarian.
Non-vegetarian, but she was not consuming much of any non-vegetarian items, right? Because egg is a very good source of protein as well as many vitamins. Then meat is a very good source for iron, and as well as fish. All these should have been included in her diet, as well as the importance of leafy vegetables and all the things we were discussing. Okay, next.
And during second and third trimester, she had adequate intake of carbohydrate, protein, iron, and calcium. And
Okay, maybe after she was
average
diagnosed of this having a little bit of anemia, she
mild
must have
anemia.
made changes
Yes,
to her diet. Okay, good.
yes.
Then
Average diet pattern include at 6 a.m. 2 boiled eggs and 1 glass of milk. 8 a.m. for idli with a sambar.
that's okay. Don't the next you can.
And then 11 a.m. Fruits such as pomegranate, papaya, guava, alternatively. Dry fruits was also included, such as dates, walnut, badam. Then at lunch, for lunch, she used to have rice, then spinach or beetroot, curd, and fish fry. Then evening, she had a glass of ragi porridge with jaggery. Then at
Okay.
night, chapati with chicken curry. And at 10 p.m., 1 glass of milk.
Okay,
And consumes
fine.
about 2
So
eggs.
ideally, you should also be asking while you're taking this nutritional history, whenever you have a patient with anemia, just ask her when she is taking her iron tablets. Most of the patients, what they do is they take all the tablets together. Okay, that may consist of iron, calcium, everything. Because if, especially if these patients are consuming ferrous sulfate tablets that are given from the government, because Kerala government is giving ferrous sulfate tablets. If they're consuming the ferrous sulfate tablets, that along with calcium, the absorption will be less. Okay. So
Okay.
we are supposed to take either on iron should be taken either on empty stomach or it should be taken at least 2 hours after taking your food. That is, we are expecting a minimum of gastric emptying time. Okay.
Oh,
So you
oh.
ask them about that also.
She took iron tablet in the empty stomach and calcium at night.
Okay, then fine, no problem. Next.
Personal history, good appetite,
No
regular.
need of all those things. Now you
Okay.
go on to the examination part.
On general physical examination, patient is conscious, cooperative,
Hmm.
well oriented to time, place, and person, moderately built and nourished. Anthropometry, height 158 centimeter. Pre-pregnancy weight 55 kilogram. Present pregnancy
So did
weight
you calculate the BMI with the pre-pregnancy weight or the present weight?
pre-pregnancy
Yes,
pre-pregnancy weight.
you're supposed to calculate BMI accordingly. Yeah.
BMI 22 kilogram per meter.
Hmm.
Then on general physical examination, pallor present. No icterus, cyanosis, clubbing, lymphadenopathy or edema. Skin normal, no thyroid swelling. Breast normal, spine and gait normal.
So what are the general examination findings that you were expecting if you had this patient who was a
Uh,
chronic anemia, who already had anemia? What all changes will be there?
there may be pallor. In
Hmm.
severe anemia, there may be edema of feet
Okay.
or generalized edema.
Hmm.
Then there will be tachycardia.
Hmm.
Then nail changes and hair changes may be there.
That is important.
Koilonychia.
Nail changes. Yeah, koilonychia.
Koilonychia.
Then dry nails, koilonychia, or platynonychia. All those things can be there depending upon the severity of anemia.
Yes.
Hmm. Okay. Now about the system examination.
Vitals were within normal limits.
Did she have tachycardia? No, right? Because her
Yes,
hemoglobin is not so low that she can have a tachycardia because of that. Yeah. 92
This is
beats per minute, because in pregnancy also you can find a little bit of tachycardia that is normal.
okay.
Mm.
Systemic examination were within normal limit.
Okay, fine. Next.
Obstetric examination on inspection, abdomen is longitudinally distended, umbilicus everted, linea nigra present, no scars, pulsations, or engorged veins. Hernial orifices are intact.
Okay.
On palpation, laxed uterus with the flanks free. Fundal height corresponds to 34 weeks. Symphysial fundal height 34 centimeter. Abdominal girth 97 centimeter at the level of umbilicus.
Okay.
Then about grips. Fundal grip, soft, broad, irregular mass suggestive of breech. Lateral grip, left lateral grip, small, irregular knob-like structures suggestive of limbs. Right lateral grip, smooth, curved resistance suggestive of spine. Then pollex grip, hard, firm, globular structure suggestive of head. It is ballotable, which indicate head is not fixed.
Actually, instead of pollex grip, you can tell first pelvic grip and second pelvic grip. That's enough.
Okay.
But second pelvic grip we usually don't do in patients who are 34 weeks. We go for it when we are
Then
conducting
after that,
examination on a term patient. Yes, after that. Because what is the use of second pelvic grip?
to confirm the findings we get in the first pelvic grip, whether the head is engaged or not.
Yes. Okay.
Then on auscultation, fetal heart sounds heard on right spino-umbilical line. Fetal heart rate between 140 to 160 centimeter beats per minute and was good. Summary. 26-year-old primary gravida at 34 weeks and 2 days of gestation with last menstrual period on May 12th, 2025. Expected date of delivery on 19th February 2026, who is on a regular antenatal checkup with history of anemia. Now came to OPD for her routine ANC visit. On general examination, pallor present. Systemic examination was within normal limits. On obstetric examination, fundal height corresponds to gestational age and fetal pulse are just palpable with good fetal heart sound.
So basically, your patient didn't have.
Diagnosis.
Okay. You can tell the
Primary
diagnosis.
gravida with singleton intrauterine pregnancy. Primary gravida with singleton intrauterine pregnancy of 34 weeks plus 2 days of gestational age, complicated by mild anemia in pregnancy.
Okay. 1 second, I have a call. I'll just leave and then join. Okay.
Okay. Okay.
ഓക്കെ അതൊരു എമർജൻസി ലേബർ റൂം കോൾ ആയതുകൊണ്ടായിരുന്നേ.
Okay.
അപ്പം നമുക്കിപ്പോ ബേസിക്കലി whenever we are talking about this patient, actually she doesn't have much problems, അല്ലേ?
Yes, ma'am.
Like it's a case of mild anemia. She had taken all these supplements and it was okay.
Yes, ma'am.
So what do you think if you repeat her if you repeat her hemoglobin and you found that it is again deteriorating, going to 9 milligrams per deciliter, what would have been the change in the management protocol?
Then we had to treat with the other modalities of iron therapy, such as intramuscular or intravenous.
But did you
And
notice that she had problems? She had dyspeptic problems, alle? And
Yes,
that's why she just changed, or that's why she didn't increase the intake of iron to twice in a day.
twice daily.
So what do you think about that?
Non-compliance to oral iron is also indication for parenteral therapy.
Yes, that's it. So there are some certain indications for that. So we'll go to it. But before that, what is the usual iron metabolism in a non-pregnant woman?
Usual?
Iron metabolism in a non-pregnant woman. Like your normal diet consists of some amount of iron. And so what do you do?
Actually, there are two types of iron, heme iron as well as non-heme iron. And this heme iron is mainly found in non-veg items, meat and all. And non-heme iron mainly in green leaf vegetables, milk, cereals, sprouts, etc. Heme iron is more readily absorbed than this non-heme iron, and it is most bioavailable form also. And the presence of heme iron also increase the absorption of non-heme iron. And amount of iron in the body is also a determining factor for the absorption of iron from the intestine. This iron maximally get absorbed from the duodenum and the jejunum. No, ma'am.
So, which form of iron usually gets absorbed? Is it ferric form or ferrous form?
Ferrous form.
Okay.
Ferrous form is absorbed, and from the androcytes, it will be converted back to ferric form.
Yes. So that's what. So if you're taking normally an average diet would consist of 10 to 20 milligrams of iron. So how much of iron would be absorbed into the body?
Only about 1.5 to 2 milligram.
That's it. Only 10 to 15% of what we eat will be absorbed. So in pregnancy, we do have an increased requirement to almost 6 milligrams to 10 milligrams per day. Right.
Yes.
So what we have to do is we have to increase the amount of
And intake.
iron intake. Exactly. So do you think that all pregnant women should be screened for anemia during pregnancy?
Yes, ma'am. Anemia is very much prevalent in our country, so that it is must
So
to
ideally,
screen.
your first trimester examination itself should include a
Screen.
hemoglobin. So a minimum
Hemoglobin.
investigation of hemoglobin, thyroid, as well as urine examination, all those has to be done when a patient comes to you in the first trimester.
Yes.
Okay. So what are the consequences? So why do you think that anemia would cause a problem in your pregnancy? What are the consequences of anemia in pregnancy?
Actually, there are maternal as well as fetal complications. Maternal complications include there is increased chance of preterm labor, then increased susceptibility to infections.
Yes.
Then there will be inability to withstand postpartum hemorrhage if the HB is very low. Then chance of puerperal sepsis in the postpartum period. Also, in severe anemia can cause congestive cardiac failure in mother. Then fetal
Fetal complications could
include fetal growth restriction, prematurity. Then sometimes may lead to intrauterine death. Then it will also lead to early, after fetus is born, early anemia of infancy and cognitive
That's
behavioral.
basically, yes, prematurity, perinatal mortality, and low birth weight babies, as well as because of this maternal anemia, there can be fetal anemia also. Yes, so that would cause other problems like mental, psychomotor performance, as well as delay in all those things can happen to the baby.
Yes.
Okay, so you have found that a patient is having a low hemoglobin. So all you had sent during your second trimester investigation was a hemoglobin. You didn't send a CBC or any other test. Okay, you were only planning to have a screening. So her hemoglobin came out to be somewhere around 9.5. So what other tests would you like to do for this patient? Like what are the other diagnostic tests that you would do in the case of anemia?
From CBC itself, we can get other red cell indices value and all. From that, we can get a clue. If the MCV, MCH, MCHC are low, we can think of this microcytic hypochromic anemia causes, such as iron deficiency anemia. Then thalassemia trait also have that microcytic hypochromic anemia. Then we can go for peripheral blood smear.
Okay.
Also, we can do other special tests such as serum iron, serum ferritin to look for the iron stores. Then
so they come under the iron studies, right? Serum ferritin, serum iron, and one more thing.
Total iron binding capacity.
Exactly, total iron binding capacity. Yes, all these come under iron studies.
Iron studies. Then we can also do look for any chronic renal disease or chronic liver disease. RFT, LFT can be done. Then urine can be tested for red cells to evaluate, look for any hematuria or presence of any pus cells. And if needed, we can do a culture also, urine culture. Then stool can be examined for any occult blood, hookworm, ova, or cyst.
Yes.
And this blood smear also to detect the malarial parasite.
Yes, all these things can be done. And HP electrophoresis can also be performed.
Yes.
HP electrophoresis would be indicated when the rest everything went to normal and this thing was like we need to know whether there are any hemoglobinopathies, we go for that.
Yes. Then we can also do bone marrow smear, biopsy and smear.
Now, yes, that is in rare cases, like if we don't get any other cause for this thing, we can finally do that also, right?
Yes, ma'am.
சாப்பிட சொன்னாங்க.
Okay. So, what are the prophylaxis that we do?
Prophylaxis
Like,
actually
we need to
WHO
prevent anemia in pregnancy. So, what are the prophylaxis that you would suggest to your patient early in the first trimester itself when she comes to you for a checkup?
first trimester diet intake can be improved. Then
Do we routinely provide iron supplements during the first trimester of pregnancy?
no,
Why?
no, ma'am. Because first trimester there is usually complicated with nausea and vomiting of pregnancy, and this iron tablet will aggravate this.
Yes. Then when do we start it?
Usually we start in the second trimester, that is from after 14 weeks and on.
So what do we give them?
According to WHO, 60 milligram of element iron and 400 microgram folic acid daily to the pregnant woman, and it should be given for till term and also 6 months after postpartum.
Okay.
3 months after postpartum.
So when do you suggest 6 months after postpartum?
According to in Indian guidelines,
Actually, for every woman, you have to give 3 months postpartum. Why? Because even though she is not anemic, you have to give 3 months postpartum iron. That is because this lady will be having a minimum of 500 milliliters of blood loss during delivery, if it is a normal delivery, or up to 1 liters of blood during a cesarean section, right? So
yes,
she's
ma'am.
having a blood loss during pregnancy, and what we have to do is we have to replenish her iron stores because she'll be lactating also, and even during lactation, the demand of iron will be high. So for every woman who have undergone a delivery, we suggest this 3 months.
Yes.
And for if the patient was already anemic at the time of
Yes.
delivery, for such patients, or if she had a history of postpartum hemorrhage or any other kind of blood loss, for those kind of patients, we have to suggest for 6 months postpartum. Okay.
Okay, ma'am.
Yeah. And so what are the Indian guidelines? So you were telling me about the Indian guidelines. So what was the program that was introduced in India as a part of preventing this anemia during pregnancy?
Actually, there are many programs from 1990s. അതെല്ലാം പറയണം മാം.
And what is the latest one that we do have now?
Anemia Mukta Bharat.
So when was it when did it start and when was it amended?
2019.
13 it was started in 2018 there were amendments. So according to 2018 Anemia Mukt Bharat program, what are the things that we have included in it?
There is a 6x6 strategy, which include 6 beneficiaries, 6 interventions, and 6 institutional mechanisms.
Okay.
The 6 beneficiaries include children from 6 months to 6 years of age. Then adolescent girls and adolescent boys of 15 to 19 years of age. Then women of reproductive age group, as well as pregnant and lactating women.
Okay, so for pregnant and lactating women, what are the things?
For pregnant and lactating women, 100 milligram of elemental iron along with the 500 microgram of folic acid to be started from the second trimester onwards and continued till 6 months after delivery.
It is actually continued till 100 days postpartum.
100 days.
So it's like 100 days. And there is also one more thing, like a minimum of 180 days during pregnancy and 100 days postpartum. So 100 days postpartum means it will come around 3 months.
Yes.
Okay, so daily 1 iron tablet or 1 folic or a combination of this, as what you have told, like 100 milligram of elemental iron and 500 microgram of folic acid. Okay. And one more thing is also included in it. What is that?
Deworming.
Deworming. Like soon after the first trimester, you're supposed to give 1 tablet of 400 milligram of albendazole to the patient. That is a single dose. Okay. So that is the Anemia Mukt Bharat program. And what is significant for anemia during pregnancy is that thing.
Yes.
Okay. So these are the things by which you can prevent anemia in pregnancy. But still your
Yeah.
patient is anemic. So what are the things? So what are the different kind of iron or iron preparations that you have? So you are supposed to
Uh,
suggest her some iron preparations, right? So what are
yes,
the
ma'am.
different kind of ore line preparations that you have?
There are ferrous sulfate, which is provided by the government itself.
Hmm.
Then other preparations include ferrous fumarate,
Hmm.
uh, ferrous gluconate,
Hmm.
ferrous bisglycinate.
Hmm.
Um, that's
These are the most common things. Ferrous sulfate, ferrous fumarate, ferrous ascorbate is there. Then ferrous
good.
gluconate, ferrous bisglycinate, and then ferric pyrophosphate is also there. Ferric pyrophosphate. Okay. And now we have latest preparations like carbonyl iron, where the iron particles are made
Maximum.
into very small, yes, very small size, and we use that. Okay. And
Okay.
there is and the latest another one is sodium ferritate, which is well tolerated. So whatever interventions are happening in the iron therapy is that all the oral ions, they're making it more compatible to the patient, more consumable, because whoever has taken these iron supplements during pregnancy would remember that it was having a very bad taste, because most of us would have experienced that.
Yes.
Okay.
Yes.
And so this taste improvement is happening every day. Now we have even sachets, like orange flavored sachets we have. So all you have to do is just open it and put it into your mouth. It will just dissolve like a candy.
Okay.
Uh, so different preparations are there. So what you have to remember is that ferrous sulfate, the absorption is good, but the gastric symptoms are very bad for ferrous sulfate. There will be blackening of the stool, there will be constipation, there will be dyspeptic symptoms. With
Okay.
ferrous fumarate, ferrous gluconate, and ferrous ascorbate, these symptoms are less. Hmm? And
Okay.
very well tolerated preparations are ferric pyrophosphate and ferrous bisglycinate. Out of these, ferrous bisglycinate has a very good absorption, but ferric pyrophosphate has a lesser absorption compared to the other one.
Okay.
So you have to keep this in mind. You don't have to by heart all these things, but all you have to understand is that whenever any patient comes to you, tells that she is having gastritis after taking the iron supplementation supplied by the government, just remember that it will be ferrous sulfate preparation. So she may
Okay.
not be finding it comfortable. So you can switch over to any of the other preparations. Still, she is not compliant, then you can go for the parental line therapy.
Paramount.
Yes. So, what are the drugs that impairs the absorption of iron? No, we were talking about different iron preparations. So earlier we told the best thing is to take it early in the morning on your empty stomach or 2 hours after any meal.
Mm.
So what are the other things that impair the absorption of iron?
Uh, uh, Taking iron tablets along with the calcium tablet will
Hmm.
impair absorption.
Which are the
Also,
other drugs that we commonly use during pregnancy?
drugs.
Hmm. Calcium
Mm.
is one. Another is
Mm.
that usually these patients during pregnancy they'll be having a lot of gastric disturbances. So the doctor will be prescribing them antacids will be there, some
Yeah.
PPIs or H2 receptor blockers, any of those kind of drugs for gastritis will be prescribed to them. All
Yes.
these can inhibit absorption of iron. Okay. And
Okay.
never ask them to take it along while if they are taking some milk or any other dairy products. That can
Okay.
again impair the absorption.
Okay.
Some antibiotics like quinolones also impair the absorption. Okay.
Okay.
And ideally, they can have it along with vitamin C because vitamin C always increase the absorption of iron. It's like 200 milligram of vitamin C can be recommended with 30 milligram of elemental iron.
Okay.
Okay, so with our 60 milligram of elemental iron, so whenever you have patients who are having iron deficiency and you're treating it during pregnancy, you can ideally combine it with a vitamin C tablet. So what is the usual dosage of vitamin C tablet that you get?
500 milligrams.
500
250
milligram it
milligrams.
is. One tablet will be having 500 milligrams. So it's like with 100 milligram of elemental iron, 500 milligram of vitamin C would be a good combination.
Okay.
Okay. Or you can simply ask her to take this tablets along with this thing. What do you call lemon juice or orange juice? All these can be combined.
Okay.
Okay, fine. So how do you assess the response to therapy in a case of anemia? That you are giving her now you are giving her oral iron. So you want to know whether she's responding to that. So how do you do that?
After 2 weeks, we can check her hemoglobin level.
Hmm.
There will be at least minimum 1 gram per deciliter rise of hemoglobin should be there.
Hmm. Okay. So how is that response happening? So when would there be an improvement in the reticulocyte count?
By about 5 to 7 days, there will be improvement in reticulocyte
Hmm.
count.
Hmm. And daily
Um,
rise of hemoglobin starts happening from the fourth day onwards. Okay.
yes.
It's like 0.1 milligram per day from fourth day. 1
Okay.
milligram, 1.1 gram per deciliter
Gram per deciliter.
from fourth day
Four.
onwards.
Okay, ma'am.
So there is no rise in hemoglobin. So what other causes has to be evaluated?
Whether she's actually compliant with the medicine,
Hmm.
actually
Hmm.
taking the medicine,
Hmm.
is it getting absorbed?
Hmm.
That means whether she's taking along with other drugs like calcium or any other antacids.
Yes, all these has to be taken care of. And also you have to evaluate for other causes if you have not yet evaluated all those causes. Okay.
Ah,
So now she is non-compliant, so you're planning to go for the parental line therapy.
yes.
Okay. So all these problems are actually indications for parental line therapy, like unresponsive to oral iron, non-compliance, intolerance, and you need a quick recovery. Like this patient presents to you, she didn't have any good antenatal checkup. She comes to you in her third trimester, and now her hemoglobin is like 7 grams. Okay, 7 or 8 grams, where you don't have a plan for blood transfusion, but yet you have to get a quick recovery of her anemia. So in such cases, you can give parental iron.
Yes.
Okay. So what are the different parental iron preparations that you have?
There are various IM as well as IV preparations.
Hmm.
Iron dextran can be given both IM as well as IV.
Okay.
Then iron sorbitol is an IM preparation.
Okay.
Then other preparation iron sucrose, pericarboxymaltose,
Hmm.
iron gluconate,
What do you usually give in your hospitals?
iron sucrose as well as iron carboxymaltose.
Those are the two preparations that we usually give nowadays. Okay. But what is the problem with iron sucrose?
Sucrose it had to be given at least multiple times. That means minimum
Yes, that
three
is the
doses
problem.
taken on alternative days.
Like
Whereas
every day would, 200 milligram per day is the usual daily infusion. So you have to give it multiple times. So that's where the importance of pericarboxymaltose comes.
yes, 1,000
So
milligram can be given in a single.
yes. In a single sitting can be given. So how do you usually give the prescription for that?
And carboxymaltose 1,000
Mm,
milligram
mm,
into 50 ml NS over
mm,
15 to 20 minutes.
That is very important because if you're trying to infuse it as a fast drip, patients can have many adverse outcomes. And is this FCM FDA approved during pregnancy?
Yes, ma'am.
No. Actually, ferric carboxymaltose is not FDA approved during pregnancy. But still we give it because of this ease. Another thing is our patients, they are very less compliant. Whenever we say they have to take multiple doses, they'll just run at that moment. So in order to have a good compliance, what we suggest is this pericarboxymaltose. Until now, we don't. Occasionally in India, there are some adverse reactions that has been reported with ferric carboxymaltose during pregnancy. But in our hospital, we didn't have any such mishaps till now. The only important thing is that we have to infuse it slowly.
Okay.
Okay, that's the most important thing. But it gives a
Okay.
very good result also. If we give this 1,000 milligram, we find a rapid response with increase in the HP content. Okay.
Okay, ma'am.
So even with this iron therapy, she didn't have much response, or you don't have much time till delivery, and she's having a hemoglobin value of 7. What do you do?
We can go for blood transfusion.
Yes, we can go for a blood transfusion, right? So what are the
Yes.
indications for blood transfusion?
If it is severe anemia, that is less than 7
Hmm.
gram per deciliter at any gestational age, is a
Hmm.
indication of blood transfusion. Also,
Hmm.
moderate anemia and the gestation age have crossed to 36 weeks.
Hmm.
we can transfuse blood. Then if the anemia is due to other hereditary disorders such as thalassemia, sickle cell disease, also in anemia facing labor, moderate anemia, even moderate anemia facing labor and cesarean section, then patient in shock or acute
Like, yes. So in any case of
hemorrhage.
acute bleeding, you have to give, like in any case of antepartum hemorrhage where the patient is sinking, or like this anemia, very severe anemia, or a hemoglobin less than 7 in the third trimester. We don't have much time for management. All these cases,
Yes,
blood transfusion, right?
yes.
Okay. So now your patient is going to deliver. So what are the intrapartum management of iron deficiency?
Uh, we can in antepartum, intrapartum we can give oxygen supplementation if the patient is severe anemic to decrease fetal distress.
Okay.
Keep the patient in propped up position.
Fine.
Then strict aseptics should be maintained. Then IV cannula site should be made for blood transfusion. Then we can shorten the second stage by using vacuum or forceps.
All these should be kept in mind, and as well as you should avoid fluid overload.
Fluid out. Then there
Because
should
that
be
will be a problem.
active management of
Active management of third stage of labor is very important. So what are the components of active management of third stage of labor?
controlled cord clamping. Then use of oxytocin.
Okay. What is the dose of oxytocin? Hmm. 10 units should be given at the time of anterior at the time of delivery of the anterior shoulder. 10 units of intramuscular oxytocin should be given. And then control contraction and delayed cord clamping പറഞ്ഞോ?
Illa.
Delayed cord clamping. Those are the most important. Uterine massage. Some advocates, but some don't give much importance to it. All these three things are very important for active management of third stage of labor. Okay.
Okay.
And so, do you want to check her postnatal hemoglobin?
Yes, ma'am.
Okay. So postnatal hemoglobin can be checked, especially in cases of anemia. Otherwise, we don't routinely do that unless there was a increased bleeding during delivery or after that. Okay. So this patient goes and then she reports with high-grade fever and foul-smelling vaginal discharge. So would you keep something in your mind?
Puerperal sepsis.
Yes. So whenever these patients come with high-grade fever and all these kind of things, you have to keep this puerperal sepsis in your mind. Correct. And now she comes to you after a while. She is feeling very tired. She is sleepless. She has some mental disturbances. So what do you think is the reason for that? She is sleepless. She has difficulty in taking care of her baby. What do you think could be?
Postpartum blues.
Because anemia can also be a cause, can also contribute to postpartum blues. Okay. Because she is like physically she is not very fit, so there can be problem of postpartum depression also. And she comes to you. So she's all fine. She comes to you at 6 weeks for a postpartum visit, a routine postpartum visit. What would you advise her?
Contraception. Because
Contraception.
repeated pregnancies can even worsen her condition.
Okay. That's very important. So what kind of contraception will you advise her?
It can give after 6 weeks intrauterine contraceptive devices or progesterone only pills also can be given.
All these can be given for her. But intrauterine contraceptive devices, do you advise for a patient with anemia?
No, there is increased risk of infection.
As well as bleeding. Because all the IUCDs for most of the patients, intrauterine copper devices or contraceptive devices, especially copper T, can cause what? Heavy menstrual bleeding. If you are suggesting Mirena or Emily, like progesterone releasing LNG IUS for her, then it is okay. Okay. Because progesterone releasing intrauterine systems usually cause decreased bleeding. We use that for a treatment of heavy menstrual bleeding. So that can be given, but they are costly in Indian settings. Usually patients don't prefer that for contraception. So it is always better to go for pills. Okay. Or she can use injectables like DMPA.
DMPA.
Dipomethroxyprogesterone acetate. What's the dose of it?
200
No,
micro.
it is a 150 milligram IM injection, which can be given every 3 months. Okay. But we don't advise using it for more than 1 to 2 years. We give them a break. There can be bone issues for them if they continuously go for it. Okay. So this megaloblastic anemia as well as the folic acid anemia should be kept in mind when you're treating any patient with iron deficiency anemia. Okay. So if she's not responding to your routine treatments like iron supplementation, you can actually think of checking her vitamin B12 levels also. And if she's deficient, you can give intramuscular or subcutaneous cyanocobalamin administration. Okay. Then hemolytic anemia is actually another topic of, I mean, it's a very vast topic. I don't think you will get much questions for that. But you should have an idea on sickle cell anemia as well as thalassemias. Okay. So management of sickle cell anemias, then what all, at least how to evaluate them. Because all these patients are on risk factor for preeclampsia, stroke, all those kind of things. And if you're treating this anemia with iron supplementations, that can be again be a problem in case of sickle cell disease. Okay, so that has to be managed in another way. And also thalassemias, if the patient is giving you any history or you find problems with their hemoglobin electrophoresis, you are supposed to counsel them, then have a genetic consultations, see if the baby is having any problems. All those have to be done. Okay. So I think Aysha was well prepared. You were answering almost all my questions. And I don't know how far your discussion goes for your exam, but I tried to cover almost all the basic things that you would be asked. Okay? Okay.
Thank you.
Okay, thank you.
Ma'am, എന്തെങ്കിലും doubts ഉണ്ടോന്ന് ചോദിച്ചോട്ടെ ma'am?
Oh.
Oh, thank you, ma'am. Any doubts from the PGs? I think there is no further doubts from the audience session, ma'am. So, ma'am, myself, Dr. Sujitra, I'm PG coordinator of Spice Route Kerala chapter. So, actually, today's session was once in a while session hour because usually we used to conduct medicine based case discussions and sessions. So, actually, it was a requested session from our side to the team Iqraa, and we thank you on behalf of entire Spice Route Kerala chapter. We thank you, team Iqraa and Dr. Fabing. Ma'am, it was a very nice session. It was a well organized session. Thank you for such a wonderful session.
Okay, ma'am. Thank you so much.
And Aysha, it was such a wonderful presentation. Thank you.
Thank you, ma'am.
Okay, thank you.
Okay.
And
Thank you. Good night.
once again, let me thank everyone on behalf of us. Thank you and good night.